of 6 to 7 years. When they erupt into the oral cavity, apex remains open. Okay, it is not closed. Okay, a permanent tooth with an open apex is called as young permanent tooth. Okay, in that conditions you do an apexogenesis. Then the other category is non-vital pulp therapy. Non-vital pulp therapy means the pulp is totally become non-vital. Okay, so the infection has progressed up to the periapical area. In that condition you do a pulpectomy if it is a primary tooth, and if it is a young permanent tooth. I told you permanent tooth with an open apex is referred to as young permanent tooth. In that condition you do an apexification. Now what exactly is pulpectomy? Pulpectomy means basically it is the removal of all pulpal tissue from the coronal and radicular portions of the primary tooth. The procedure should be termed as partial pulpectomy. Why it is called as partial pulpectomy? Because you cannot remove the complete pulp from the primary root canals. Basically, the difference between permanent root canal, if you see the morphology of permanent root as well as the primary root, what happens is primary root canals have multiple lateral canals, multiple ramifications are present, while that is not the case in the permanent tooth root canals. So as a result, what happens is pulp gets entangled in various lateral canals. So complete extirpation of the pulp as a single tissue as it happens in permanent tooth is not possible in primary tooth. For this reason, what we have to do is that you cannot always remove the pulpal tissue completely. Certain amount of pulpal tissue will be left out, which doesn't cause any problem provided you do a good obturation and a coronal seal. So that's the reason the primary tooth pulpectomy in primary tooth is referred to as partial pulpectomy. Now, why you want to do pulpectomy? Basically, the objective is that you have to maintain the tooth free of infection. Okay, then you have to biomechanically cleanse the tooth, root canals, and obturate the root canals. Always you obturate the root canals of the primary tooth with a resorbable material. What is resorb? Resorb means as the primary tooth, the root of the primary tooth often keeps on resorbing gradually. Okay, as it keeps on resorbing, the material also should resorb. That is the reason you don't use gatta parcha in primary tooth. Why you don't use gatta parcha? Because gatta parcha is not resorbable. So only you use a resorbable obturating material in primary tooth. Okay. Apart from that, the other objective is that it has to promote the physiologic root resorption and have to hold the space for erupting permanent tooth. Now, when do you do a pulpectomy? Generally, pulpectomy is very essential when a second primary molar is infected. Basically, it is infected and there is a pulpal involvement because of caries before the eruption of permanent first molar. If there is a presence of draining fistula, if you are planned for a pulpotomy, after removing the coronal pulp tissue, the bleeding is continuous. That time you have to do a pulpectomy. Generally, in a pulpless primary tooth with sinus tracts, as well as pulpless primary tooth without permanent successors. In these conditions, it is recommended to do a pulpectomy. But when you want to do a pulpectomy, you have to evaluate certain criteria. That includes the tooth should have sufficient structure. Tooth structure should be there. Okay, at least 3 walls of the tooth should be there. If there is missing of more than 1 wall, the restorability is questionable. In that condition, better not to do a pulpectomy, go for extraction. Then there should be adequate remaining root. Okay, since the primary tooth always keeps on resorbing, at least 2/3 of the root should be there. 2/3 of the root should be there to perform pulpectomy. And above all, the patient should be cooperative for performing the procedure. These 3 are very important considerations when you are planning for a pulpectomy in a primary tooth. Now, what are the contraindications when you don't do a pulpectomy? You don't do a pulpectomy basically when the tooth is not restorable. Okay, if there is loss of more than 1 wall of the tooth, then it is not recommended to do a pulpectomy, because the main objective of doing pulpectomy is to restore the tooth back to function, which will not be possible if there is loss of more than 1 wall. Okay, a tooth with a mechanical or a carious perforation at the floor of the pulp chamber is also a contraindication because there is a perforation. Pathologic root resorption more than 1/3. I told you, if you want to do a pulpectomy in a primary tooth, at least 2/3 of the root should be present. If the resorption is more than 1/3, automatically the remaining root becomes less than 2/3. So it is not indicated for pulpectomy. When there is excessive loss of bone support, when there is presence of a cyst, or there is severe mobility or the patient is medically compromised, like because of congenital ischemic renal problems. In that conditions, it is better to not do a pulpectomy and go for extraction. Now, what are the various endodontic instruments you use for a primary tooth? Basically, you have to make a good access opening. After doing access opening, you can locate the root canal using explorers. Endodontic explorers are very useful in locating the root canals, orifices, as well as smooth broaches. After locating it, you can debride it with the help of you extirpate the pulp tissue and remove the debris. To extirpate the pulp tissue, the most commonly used instrument includes barb broach. Okay, you should be very careful when you're using in the primary tooth. The reason is because the primary root canals are very tortuous. Okay, they are very curved. The multiple ramifications are there. This instrument, what you use, should not get stuck inside the canal. If it gets stuck inside the canal, chances of breaking is very high in primary root canal. So you should use a size which is freely placed inside the canal so that you can extirpate the pulp tissue. Then shaping the root canals includes files and reamers. Most commonly you use files. You don't use reamers in primary tooth. Very rarely used for shaping. Most of the time you use files largely to enlarge the canals. Okay. After that you obturate it with either with pluggers and lentular spirals. So barb broach is largely used for extirpating the pulp tissue. H file is also used to extirpate the pulp tissue, but it is also used to enlarge the canals, lateral wall of the canals. Okay, H files have more flutes, whereas reamers have less flutes. H files are rectangular in cross section when you see, okay, in a closer aspect, whereas reamers are triangular in cross section. Okay, they have something called as K flux file. This is very useful, especially in the primary root canals, because it is very much flexible. Okay, even in the curved canals, you can, the chances of breakage is very less if you use a K flux file. Okay. Now coming to the procedure, pulpectomy procedure. First and foremost thing is, I told you what are the indications, what are the considerations that needs to be taken. The tooth should be restorable, the patient should be cooperative, and there should be at least 2/3 of the root before doing the pulpectomy for a primary tooth. So first and foremost thing is, you should have a very good and clear radiograph. Okay, before starting the pulpectomy, you should have a very good, clear intraoral periapical radiograph. After that, what you do is that once the patient is cooperative, you give the anesthesia. Okay, most of the time, if you are doing for a lower primary teeth and the child is above 6 years, it is better to do a inferior alveolar nerve block if you are doing for posterior teeth. Okay, if it is for lower posterior teeth, if the child is more than 6 years, it is always recommended to better to go for inferior alveolar nerve block. Okay, if the child is very young, 4 years, 3 years, in that condition you can try for infiltration in the lower teeth, whereas in the upper teeth, for all the teeth, infiltration will be very effective when you give an anesthesia for pulpectomy procedure. After giving anesthesia, you do a isolation with the rubber dam. After rubber dam isolation, you start doing the access cavity. So how should be the access cavity? The access cavity, the main reason of doing the access cavity is that you should use the all the instruments, whether you're placing a file or a broach, it should enter the canal without touching any wall of the access cavity. It should be so clear, so that you have a straight line access. First and foremost thing is that you should obtain a straight line access, but at the same time, you should not remove the tooth structure unnecessarily. You conserve the tooth structure as much as possible. Okay, don't remove the tooth structure which are sound, okay, which is infected by caries. Only those structures should be removed and maintain an straight line access. After that, you have to remove the roof completely. Only if you remove the roof completely, you will be able to see the all the pulpons as well as the orifices. Once you have made a good access cavity with clear visibility, that time you start with using the instruments. Okay, so whenever you are placing any instrument, it should not touch any walls. It should be clear enough to straight reach into the apical area of the canal. Okay, so first and foremost thing is, you have to remove the coronal pulp tissue. After making the access cavity, first what you do is that you take a spoon excavator, remove all the coronal pulp tissue from the coronal pulp chamber. Once you remove it completely, what happens is you can clearly see the root canal orifices. Then you take a small broach, okay, which freely fits inside the canal. Okay, not a too big broach. If you take a bigger size broach, chances of getting entangled in the root canal is high. So take a small size broach that freely moves inside the canal. Okay, rotate it in a watch winding motion and pull the rotate it one quarter turn. You just give and pull it out so that you remove the pulpal tissue. Okay, after removing all the pulpal tissue, irrigate the canals nicely. Most of the time, what are the irrigants that can be used is most commonly used is physiologic saline solution. Okay, physiologic saline solution is commonly used. You can use even sodium hypochlorite and hydrogen peroxide, but chances is that they should be very careful when you're using a primary tooth because the roots of the primary tooth are often resorbed. Okay, chances is that if you irrigate too much of sodium hypochlorite, chances of going beyond the apex is very high with primary tooth. So if you're using a sodium hypochlorite or hydrogen peroxide, the quantity should be very minimal. But saline is no, there is no issue if you use in copious amount of saline. You can also use stream of hot water as well as solution of chloramines. So once it is irrigated, once you have removed the pulpal tissue, you determine the working length. Working length is determined either by tactile method. Tactile method is you place the file and you feel it, the apex with the tactile sensation. Okay, or you can use a radiographic method by placing the file, take a radiograph, or you can use even electronic apex locator. These are commonly used method for working length determination. Once you have enlarged the canal, you can enlarge the canal either with H files or K files. When you're using the H files, don't rotate it continuously. Chances of getting entangled in the canal is very high. But if you're using a K file, you can always use it in a watch winding motion and remove all the debris. Once it is often using the files and repeated irrigation is required with saline. Okay, once it is enlarged up approximately to a size of 30, then dry the canals with paper points and obturate with the suitable material. Most of the time, the obturation material for primary tooth should be a resorbable material. So you don't use a gatta parcha. Gatta parcha is not resorbable. Gatta parcha is not used for primary tooth obturation. Gatta parcha is used only for permanent tooth obturation. For primary tooth, you use a paste called as Metapex or White Apex, which I'll be talking in the later part of the lecture. After doing the obturation, you take a radiograph, you see that the obturation, is still the apical third, then you have to go for a final restoration. The final restoration after endotherapy is stainless steel crown. Stainless steel crown is largely recommended for primary tooth. The reason is because the success of pulp therapy largely depends on the maintaining an adequate coronal seal. After selecting the case properly, you do a very good obturation, but you don't give a crown. Okay, the restoration what we have given, either it is a composite or a glass enamel, if it fractures, then chances of secondary infection is more. So as a result, it is always recommended to give a stainless steel crown after pulpotomy or pulpectomy. The reason is because chances of tooth fracture as well as the restoration fracture is very high. For that reason, it is always recommended for long-term success to give stainless steel crown after doing a pulpotomy or a pulpectomy. Now, what are the commonly used root canal obturating materials in primary tooth? So, any obturating material you use for a primary tooth, first and foremost thing is it should be resorbable. Okay, then it should have an antiseptic property. It should be non-inflammatory and non-irritating to the underlying permanent tooths. It should be easily inserted. It should not be soluble in the water. It should not discolor the tooth. Okay, it should not make the tooth change its color, and it should be radio opaque. When you take the radiograph, it should be radio opaque. These are some of the qualities of a obturating material that is used for primary tooth. Okay, some of the commonly used material for obturation for primary tooth is, I again repeat, you don't use gutta percha for obturating primary teeth. Gutta percha is used to obturate only permanent teeth. For primary teeth, you can use zinc oxide eugenol paste, you can use White Apex or Metapex, you can use endoflass. These are some of the obturating materials that are available. Okay, zinc oxide eugenol contains a main component as zinc oxide eugenol, whereas White Apex or Metapex contains calcium hydroxide and iodoform. These two are the major constituents in White Apex. In endoflass, you use barium sulfate along with calcium hydroxide and iodoform. Zinc oxide eugenol has a disadvantage is that it has a very slow resorption rate compared to the root resorption, whereas White Apex has a adequate resorption rate. It resorbs along with, as the root resorbs, it also resorbs regularly. So Vitapex and Endofloss are more preferred than zinc oxyreginol. If you don't have any option to remove zinc oxyreginol, other disadvantage of zinc oxyreginol is that if it goes beyond the apex in the primary tooth, it often tends to deflect the eruption of permanent tooth. That means it changes the eruption path of the permanent tooth. This is also reported. So for that reason, largely it is preferred is Metapex or Endofloss rather than zinc oxyreginol paste. The other forms of obturating material that is available that are based on iodoform includes KRI paste. Okay, it contains iodoform at 80%, whereas Maestro paste contains iodoform at 42 gram. Whereas walk-off paste also contains iodoform along with camphor and menthol. Okay, these are all are iodoform based paste. They are found to have antiseptic and antibacterial activity when used as an obturating material. So what are the technique for obturation of primary tooth? Obturation of primary tooth is basically you don't have gatapacha. If it's a permanent tooth, you take a gatapacha stick and place it there, and gradually you do a lateral condensation. Okay, whereas in this you don't have a stick, you have a paste. So placing the paste as different techniques. You can use an endodontic pressure syringe to deliver the material directly into the root canal. You can use a mechanical syringe, or you can use an incremental filling technique. What is this incremental filling technique? Incremental filling technique is you fill the canal, then you take a endoplugger, push it inside. Then again you fill the canal, little amount of material is placed inside the canal and push it with the endodontic plugger. This is referred to as incremental filling technique. You can use even lentulospiral. Lentulospiral here is used with a slow speed handpiece. Okay, what you do is you mix the material and take the material in the lentulospiral and place it inside the canal and then run the lentulospiral. Okay, this is also gives a very good results for obturation. The other material, the other equipments that can be used for obturating the primary teeth includes tuberculin syringe, amalgam plugger technique, as well as plugging action with wet cotton. There can be single visit pulpectomy, multi visit pulpectomy. Single visit pulpectomy is done when there is a patient does not have any abscess, any chronic sinus is not present. Okay, and the patient is cooperative, you can always go for a single visit pulpectomy. If it is a multi visit pulpectomy, if the patient is having an abscess, okay, there is a draining sinus, okay, if there is a chronic infection, in that conditions, what you do is first visit you do an access opening, debride the canals, irrigate the canals nicely, give a plain cotton dressing. Over that, you give a temporary filling and recall the patient after 1 week. After 1 week, you do a obturation, okay, so that the abscess would have subsided. Okay, in that conditions, it is referred to as multi-visit pulpectomy. Otherwise, it is all if there is no abscess or there is no any sinus, draining sinus, it's better to do a single visit pulpectomy. That's all for today's lecture. If you have any doubts, you can always ask.